Good afternoon. Welcome to today's webcast entitled Not So Common Knowledge About the Most Common STI, Diagnosis and Treatment of Trichomonas Vaginalis, presented by Dr. Jane Schwebke, Professor of Medicine and Infectious Diseases, University of Alabama at Birmingham. Following the talk, we'll have a short question and answer session. You can ask questions at any time during the presentation via the web using your Ask a Question box. If you should need technical assistance, type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected, you can log on again using the instructions provided to you for accessing this webcast. If you cannot log back on, please call 877-843-9272. It is now my pleasure to turn the webcast over to your speaker, Dr. Jane Schwebke.
Thank you very much, and thank you for joining us in our webinar about Trichomonas. I hope we will accomplish a lot this afternoon. First of all, let me display our disclosures, and I'll let you read those as you wish. And we will then proceed to ask you a few questions, some audience poll questions. But first, let me mention our learning objectives. By the end of this webinar, participants will understand the epidemiology and prevalence of Trichomonas vaginalis, current diagnostic techniques for this infection, complications and risk factors of untreated infections, and treatment guidelines and options for treating Trichomonas as well as resistant Trichomonas. So here goes our polling. Which best describes your practice today? Give people a minute to figure out what they're doing with their life here. So it looks like we have a lot of other, and I'm guessing that maybe a lot of that is laboratory personnel, but I'm not sure. What are your perceptions of Trichomonas infections? TV is a harmless nuisance. If left untreated, it can lead to adverse health consequences. It's easy to diagnose and treat, both A and C or both B and C. Okay, looks like a lot of people think both B and C. A few other people have other ideas. What tool do you primarily use to diagnose Trichomonas today? Do you go to the microscope? Do you use BD Affirm, NATS testing, or other? So about half of you go to the microscope, about a third of you use BD Affirm, about 8% use NATS testing, and then 12% other. How sensitive do you think that wet mount is? Anywhere from 50 to 100% sensitivity. So it looks like most of you think it's about 60 to 50%, 50 to 60% sensitive. And how soon after preparing the slide do you read the wet mount? Do you read it immediately, within 5 minutes, longer than 15 minutes? Okay, well, it looks like most of you are getting to that microscope pretty quick, and that's good. Within 15 minutes, a few. Okay, so now that we know a little bit about you, let's talk a little bit about Trichomonas. So women present with complaints of vaginitis, vaginal discharge, odor, irritation, very commonly. It's estimated that there's about 12 million office visits per year for this reason. And the key players in this, as you see here, are Trichomonas, bacterial vaginosis, yeast infections, and then chlamydia and gonorrhea infections. And you can see that there's a lot of overlap in terms of the symptoms that women present with. And that makes it very important that we don't rely just on symptomatology, but that we do objective testing to try to figure out which of these problems they have, and sometimes they can have multiple problems. So it is very important to do objective testing so that we can properly diagnose and treat and manage these problems for these women. Trichomonas vaginalis is a parasite. It lives in the urogenital tract of males and females. There are other species of Trichomonas. There is one that can live in the mouth. There's one that can live in the GI tract. But they're very fussy about the places they want to live. So Trichomonas vaginalis is only found in the urogenital tract. It attaches to vaginal epithelial cells, the squamous epithelial lining of the vagina, and it releases proteins and enzymes that destroy the cell, and in so doing can elicit a very intense inflammatory response. However, as with any STD, there's a spectrum of symptoms. So you can have women that are completely asymptomatic, and then women who have terrible, terrible inflammation and irritation as a result of this infection. This is just a schematic of the transmission of Trichomonas vaginalis. Of course, it is a sexually transmitted disease, so sexual partners pass it back and forth pretty readily. The modal trichomonads that we see on the wet prep are trophozoite forms. To date, I don't think that anyone has been able to identify a cystic form of the organism, as we do see in other parasitic infections such as Giardia. So only the trophozoite form is known thus far. Although a lot of people don't think that Trichomonas is in their backyard, it certainly could be. There was a National Health and Examination Survey recently, a few years back, I believe, that found that overall in the U.S. population, Trichomonas affected 3% of women. And that may not seem like a lot, but remember that's spread over the entire representative sample of the United States, and it was certainly higher in other, in more specific risk groups. And if you look at the annual incidence of STDs in the United States, that's the annual number of new cases of STDs, you can see that Trichomonas is the winner, with 7.4 million cases estimated to occur each year. Even more than HPV, which we certainly think of as a very prevalent infection as it is. And I think it's important to point out, too, that Trichomonas is the most prevalent curable STD that we have as well. If you look at the prevalence of Trichomonas by age group and compare it to chlamydia and gonorrhea infections, it's kind of interesting because, as we would expect, gonorrhea and chlamydia are quite prevalent in younger age groups and then decline with age. But Trichomonas, even though it is certainly also an STD, starts out at high levels and continues that way, and in fact has a peak toward the fifth decade of life. So this is a little puzzling to people, and they wonder why this is. I personally think it's because we don't have any kind of control program for Trichomonas. Until recently, we've really had no way to even test for Trichomonas in men, and we've certainly not had a sensitive test for detecting Trichomonas in women. So I think what you're seeing here is sort of a cumulative prevalence of infections in women as they progress through their lives. We mentioned earlier that, as with any STD, Trichomonas may be asymptomatic, and it's estimated that it's asymptomatic in as many as 50% of women. And it is certainly asymptomatic in the majority of men. In a recent study that found 72% of male partners of women infected with TV were also infected, 75% of those men were asymptomatic. So although it can cause non-gonococcal urethritis, the majority of men who are infected are without symptoms and certainly then are not aware that they're infected. In terms of complications of untreated infections, it has been associated with atypical PID, and the woman that comes to mind for me with this is the woman who comes in complaining of sort of vague abdominal pain. You're thinking about PID in this woman. When you do your exam, she really doesn't have the typical signs of PID. She may not have cervical motion tenderness or adnexal tenderness. She may have, yet when you look under the microscope or test her in other ways, you find Trichomonas, and when you treat that, her unusual abdominal pain sort of dissipates. So I refer to that as atypical PID from Trichomonas in that case. It's certainly been shown to be an important risk factor for acquisition transmission of HIV in several studies. And this is like other STDs, probably the mechanism is that you have inflammation and disruption of the mucosal epithelial layer of the vagina, and so the HIV virus has an easier way to get in, and that's sort of a simplistic way of thinking about it, but I think the easiest way to think about it, there certainly are other factors involved in terms of the inflammatory cells that come to this site, having CD4 receptors, etc. But it clearly is a risk factor for acquisition transmission of HIV. It's also been associated with acquisition of other sexually transmitted infections. It's been shown to be a risk factor for post-hysterectomy infection, and it has been shown in several studies to be significantly associated with preterm birth, low birth weight, and preterm rupture of membranes. So most of you said that you use the microscope for diagnosis, and it certainly is fast and inexpensive way to do that. Unfortunately, it does lack sensitivity, as we'll see in a minute, and you do have to get there in a timely fashion, and it looks like most of you are trying to do that. But I don't know about you, half the time I get interrupted as I'm on my way to the microscope with a question from a nurse or a colleague or a patient or whatever, so sometimes there is a delay. But you can see from this study that the faster you get to the microscope, the better your yield of finding viable trichomonads. And then in terms of sensitivity, we have to realize that you have to have sort of a threshold of organisms to be able to find Trichomonas under the microscope. So you can see here from numerous studies that the sensitivity of the wet prep is really only about 50 to 60%. In the best of hands, in somebody who's doing research and doing this all the time and is a great microscopist, you can probably get up to 80%, but I don't think you can get any better than that. In the past, we've always recognized, I think, the limitations of wet prep, and in the past the gold standard was culture for the detection of Trichomonas, but culture has never been widely available. It's somewhat complicated. It's I think a moderate complexity test for CLIA. You have to have an incubator on site, and you have to have a laboratory that's CLIA approved for this moderate complexity type of test. So it's never been widely available. Now, however, we do have nucleic acid amplification testing available to us on a commercial basis for detection of Trich. And this, of course, is an amplified testing method. People, before this was available, people were trying to use homegrown PCR primers to amplify the organism so that they could have better detection methods, but there was quite a lot of variability, as you can imagine, in the primers that were designed and in the performance of those homegrown tests. So I think a year or so ago we did have the FDA approval of NATS testing for Trichomonas in women. Unfortunately, we do not have that same FDA approval for testing in men simply because the test wasn't presented to the FDA for that indication, but it is available in laboratories, in some laboratories who have gone ahead and used the same testing platform as for women in men in what we call an ASR format, analyte-specific reagent format, where they use the same reagents and they do internal quality control and validation to show that the test can be valid for screening men for Trichomonas as well. So that's both the increased sensitivity, as you can see here, 100% sensitivity basically for NATS testing in women, and now the availability of testing for men, whereas before we really had nothing for men, I think has been a great change for us. In terms of screening recommendations from the CDC, they do recommend specific testing for Trichomonas in women who present with vaginal symptoms. They say that screening for Trichomonas should be considered in those at high risk for infection, so those would be people who are at high risk for sexually transmitted diseases in general, and that screening should be conducted at least annually for all HIV-infected women. And I think this last point is kind of an important point, because if you think about a few slides back when we talked about the complications associated with Trichomonas, we mentioned that it was a significant risk factor for acquisition transmission of HIV. So in terms of decreasing transmission of HIV from people who are attending HIV clinics, I think it's important to screen for STDs in general, including Trichomonas, to decrease the chances that they will be shedding HIV virus in the genital tract. And we just recently completed a study in our HIV clinic in Birmingham, Alabama at UAB, of Trichomonas, and this was by culture, so we've probably underestimated the true prevalence, but we found that the prevalence of Trichomonas in these HIV-infected women was around 18%. So that is highly significant. And the other problem that we've had in screening for this is that not all HIV clinics, in fact, I don't think most HIV clinics have microscopy on site, so I think it's been a real hurdle for them to institute this kind of screening, even by microscopy, in their HIV-infected women. So I think that the development of a commercially available NATS testing will benefit this group of patients. Now, I must say that I'm very proud of the state of Alabama because, to my knowledge, we were the first state public health laboratory to initiate the NATS testing for screening for Trichomonas. And I thought this was a huge accomplishment for Alabama. So we have been using the NATS testing platform for chlamydia and gonorrhea, of course, for some time. And about a year ago, with the availability of the NATS testing for Trichomonas, that was added to our repertoire of testing. And even beyond that, to my amazement, the state lab went ahead and did the internal validation necessary to use the same testing platform as an ASR, as I mentioned before, for men. And so we started screening all our STD clients, male STD clients as well for Trichomonas, again, along with the gonorrhea and chlamydia testing. And I don't have formal data, I'm afraid, although I'm dying to get my hands on it, but I do know that in the month of January, we identified 48 additional cases of Trichomonas infection. I don't have the breakdown by gender, but from individuals who either were women who were wet prep negative or men who were screened now for Trichomonas. And just to give you some sense of our clinic, we see about 10,000 patients per year, and about half are male, half are female. So I'm personally, since I like Trichomonas, I'm very excited about this program, and I think that we will be detecting a lot more additional cases. I should mention, and I failed to mention this before, that for women, specimen types can vary, and the FDA-approved NATS testing can be used on vaginal specimens, endocervical specimens, and liquid-based Pap screen media as well. So you do have those options. We, in our clinic, are just using it with our endocervical specimen that we obtained for gonorrhea and chlamydia testing. So, you know, there's an interesting phenomena going on, I think. For myself, who's been in STD control for 25 years, it's kind of distressing, but there are a lot of categorical public health STD programs that are closing their doors, primarily for lack of funding. So that's a problem for patients in those areas that, you know, used to use those types of clinics and now have really nowhere to go. And so I think along with that and along with healthcare reform, in which theoretically all Americans will have healthcare insurance, that we're going to be seeing more and more of these patients and these problems in the in the private health sector. And so I think we need to get prepared for that. And a lot of private practitioners have maybe not been used to seeing quite the rates of STDs that they might see in the future as a result of this shift in patient populations. So I think we need to brush up on these areas of STD control, testing, treatment, because I think we are going to be faced with those issues very soon. Shifting gears into treatment. Treatment is usually pretty straightforward. Metronidazole, 2 grams PO stat single dose is what is primarily used, which is great because it's single dose and it's inexpensive. Tinidazole is another option as a 2 gram single dose treatment. It is just more expensive than metronidazole, and unfortunately it's more expensive because actually it has better pharmacokinetics against Trichomonas than does metronidazole. And I think tinidazole's place right now is perhaps in the arena of metronidazole resistance. So if you have a woman who you've treated for Trichomonas with the 2 gram stat dose and she comes back and still has it and swears she hasn't had sex, I think you need to start to assume that the isolate may be resistant. You can send isolates to the CDC for testing, but of course it's not kind of real time. It's going to take you a while to get those results back. And in our hands, we actually didn't find a high correlation between clinical outcome and the level of resistance. So what most people do is go ahead and move to treatment at that point with either a week of metronidazole, 500 BID for 7 days, or I prefer, if the patient can afford it, to move right to tinidazole with its superior pharmacokinetics and do something like 2 grams a day for 3 to 5 days of tinidazole. There are no randomized treatment trials for these studies, as you can imagine, because the amount of resistance is still relatively low. There are just a few studies that have looked at the prevalence of resistance to metronidazole, and they're in the ballpark of about 5 to 10%. So that's about what we can anticipate. Hopefully that next step of treatment will work, but I and many others have had patients who've been seemingly completely resistant to Trich, and you think, oh my God, they're going to have to live with Trichomonas their whole life. But you can try other things. Paromomycin intravaginal cream can be made up by a compounding pharmacy and used intravaginally for several days. 2 problems. Again, it's very expensive, and it can cause some significant vaginal irritation, so you have to watch out for that. Boric acid intravaginal suppositories has been tried and used successfully in a few reported cases. And one of the regimens that I had success with in a woman who had been unsuccessfully treated for nearly 2 years was a combination of oral high-dose tinidazole, and that was 3 grams a day, a lot of tinidazole, and intravaginal paromomycin cream simultaneously. And I was able to cure her with that, and that has been reported in the literature as well. So there are some options, but they get a little dicey, and if you're not a true, if you don't see a lot of resistant Trich, it's probably a good idea to pick up the phone and ask an expert in consultation about these problems. In terms of pregnancy, I still hear a lot of people saying, oh, no, you can't use metronidazole in the first trimester of pregnancy, but in fact, there have been meta-analyses which have shown that there has not been a demonstration of an association between metronidazole use and untoward effects in infants. And in the CDC 2010 treatment guidelines, it clearly states that you can use metronidazole even in the first trimester of pregnancy, so that really shouldn't be an issue. One topic that has been coming up a lot over the last several years has been expedited partner therapy. And what this means, or EPT, what this means is that you identify, let's say, Trichomonas in a woman, but perhaps it's going to be difficult to get her male partner to seek medical care for whatever reason. And as an aside, it's estimated that only about 20% of male sexual contacts of women with Trich get treated. So EPT is basically giving the female, in that case, medication to take to her partner to get him treated. And a lot of caregivers have reservations about this because they are afraid there will be legal ramifications of giving medication to a patient that they've never seen. But the CDC has provided us with a map, and here you see it, of legal status of doing this expedited partner therapy in various states. And it does vary, but it is permissible in 32 states. It is potentially allowable in 11 states, and there's like wiggle room in the language. And it is prohibited in only 7 states. So the majority of states, you would be able to legally provide this type of therapy for partners. So that's something to keep in mind if you think you're going to have trouble getting the partner into treatment. Okay, so we're going to repeat some of these questions for the audience. Trich is a harmless nuisance. If left untreated, it can lead to adverse health consequences, easy to diagnose and treat, or a combination of the above. Let's see what people think. So most people, it looks like, are choosing both B and C. It can lead to adverse health consequences, and it's easy to diagnose and treat, and I would agree with that. Based on what you heard today, would you consider NATS testing to diagnose Trichomonas? Yes, no, undecided? Wow, looks like 100% say that would be something to definitely consider. Oh, no, there was 3% that popped up on the end. So in conclusion, I think today we've covered actually a fair amount of territory in 30 minutes, but we realize that wet mount, even though it is fast and easy, and I'm certainly not saying you shouldn't do wet mount, but it will miss the diagnosis in 50% of cases, so you need to be aware of that. Trichomonas can be associated with adverse health consequences, and we now have commercially available NATS testing to a more sensitive method to diagnose trichomonas in women, and now a method in certain laboratories to diagnose trichomonas in men. So thank you for your attention. Let's see what kind of questions we have going on here. So here's our first question. If a patient has normal vaginal pH, do you still test for Trich? And that's a great question, and I should have mentioned sort of the parameters that you would look at when you're trying to differentiate different kinds of vaginitis. So in our clinic, we do what's called a vaginitis profile, sort of at the bedside in the stat lab, where we check the vaginal pH, and remember that the normal vaginal pH is 4.5 or less. It's kept acidic by the lactobacilli that are the good guys in the healthy vagina. And using the vaginal pH as a guide, we can sometimes, or oftentimes, sort of reach a branching point. So, for example, if a woman has a normal vaginal pH, she doesn't have BV. That's a given. But if a woman has a normal vaginal pH, could she have trichomonas? Yes, she could. In fact, 10 to 20% of the time, you'll find trichomonas in women with a normal pH. You usually won't find very many of them because they don't like that. They like it to be more alkaline. They're much more comfortable in an alkaline environment. So your chances of finding them on a wet prep are greater if the pH is high, but they certainly can be present with a normal pH. The other parameters that we look at in our vaginitis profile are, of course, the other components of the Ansel criteria for BV. So, well, and microscopy for everything. So, of course, microscopy we look at for yeast, clue cells, and Trich. And the whiff test we do. And as well, we do look at the vaginal discharge, but that can be very subjective, and I definitely do not recommend empiric treatment over the phone or just based on looking at the discharge. So I hope that answered the question about pH. Let's see. Why would I test a patient for Trich if I'm just going to write a prescription for Flagyl anyway? Well, I hope that's not what you're going to do. I hope that you are going to try to find some objective evidence for what type of infection this woman has. I think she deserves that. I think it's very important. Yes, if you write a prescription for Flagyl, will you cover BV and Trich? Yes. Will she know that she has a sexually transmitted disease? No. Will she know that she needs to get her partner treated for Trich? No. So there is a lot of ramifications for just treating empirically. As a woman, I would want to know that I had an STD so my partner could get treated so he didn't give it back to me. And I would also want to know that my partner gave me an STD because I think this would have important implications for how I make decisions about that relationship. So I think we owe it to women to do a better job in screening and differentiating the different causes of vaginitis and making sure that they're informed about what we're doing for them or what we're not doing for them, for that matter. Let's see. What do we have here? Is there any evidence studies that women can have low-grade asymptomatic infections that persist for multiple years and go undetected? And how many years can these infections persist? I think we've all probably encountered the 80-year-old woman with trichomonas reported back on her pap smear and gone, wow, and kind of not believed it. But the fact of the matter is that if it's reported on a cytology, it's likely to be real. And it could be that it has just gone undetected for many years. It could be that she just got it, but it could be that it's just gone undetected for many years. How many years, I can't say. I don't think we have any studies to look at that, but it certainly is possible that she's been asymptomatic this whole time and has never been screened for trichomonas. Okay. What is the prevalence of Trichomonas vaginalis among women who have sex with women? Well, that's a good question. We often think about women who have sex with women as being at lower risk for sexually transmitted infections, and I think that's certainly true for certain STIs, such as gonorrhea and chlamydia, but when it comes to vaginitis, that's not true at all. And women who have sex with women are at high risk for bacterial vaginosis and for trichomoniasis. So this is a case where you'd want to certainly do diagnostic testing in women who have complaints, and then also get their partner in for testing and treatment, and just be aware that this can be an issue in this population. So yes, this can definitely be a problem in women who have sex with women. Okay. What is the rate of metronidazole resistance? Well, I mentioned that there were only a couple of studies who really looked at this, and one was a CDC study that looked at samples from, I can't remember how many sites now, I'm going to say 6 sites across the nation, and I think they found the prevalence to be around 5%. We did a study in Birmingham some years back and found the prevalence to be closer to 10%, but there are, like I said, very few studies out there, so somewhere between 5 and 10%. And I would guess that if you take care of women with trichomonas, you will encounter this at some point, so it is something to be aware of. Let's see. Okay. What is the recommended follow-up for TV positive patients? So should you retest? Well, that's a good question. There is no recommendation for retesting, test of cure, if you will, in Trich positive women. For the most part, the therapy should be 98% effective, even the single dose metronidazole, as long as their partner or partners get treated as well. So at this point in time, there's no recommendation, no formal recommendation. Certainly if they come back and say their symptoms have persisted or they've been in contact again with an untreated partner, that would be a case for a retesting and possibly retreatment. Let's see. Oh, this is a good one. How often is Trich the culprit behind vaginosis when compared with Candida or BV? I like that. It's a cute culprit. So I can just tell you, well, I can share with you the prevalences of vaginitis in our STD clinic in Birmingham. Of course, keep in mind, we are in the southeastern United States, which has high rates of STDs, and it is a public health STD clinic, but it's kind of shocking, really. I don't have a great handle on the incidence of Candida because I'm not as interested in it because it's not an STD, but I'm going to say maybe about 15% of our women have candidiasis. About 70% of our women have BV, if you can believe that, and Trichomonas has remained constant in our clinic I've been there 18 years, probably over the last 18 years at 25%, and that's detected by culture. So that's probably a low estimate of what we have. So I am really going to be interested to see what our prevalence in women looks like after we've instituted the more sensitive NATS testing. I think that's going to be fascinating to look at that and see what we have. But it's very common in our clinic. Otherwise, if you look at the relative incidences, it's probably the same, or it could be shifted. I would say that BV is always going to be probably the most prevalent vaginal infection in women. And then depending on the populations you work with, either followed by Trich or Candida. I hope that answered your question. Oh, another good question. How long after treatment will a positive NATS test remain positive? And I assume you're speaking specifically for Trichomonas. And I must say we don't have really great data on that. In a study that we did, if I'm recalling correctly, and sometimes I don't even can't even quote my own work correctly, so bear with me. But we did have the capability of repeating NATS testing for Trichomonas in women that we treated with metronidazole in a 5 to 7 day period after treatment. And if I'm recalling correctly, about 40% were still positive in that time frame. So that's a relatively short time frame compared to what we usually say for NATS testing for gonorrhea and chlamydia, which is more on the order of 2 to 3 weeks that it could remain positive because of dead DNA. So I would have to err on the side of 2 to 3 weeks as a reality, but I don't know the answer for a fact. But it is something to keep in mind if for some reason you need to do repeat testing. If you do it too soon, you may have a false positive because of dead organisms. In my institution, how do I test for yeast vaginitis? That's a good question. We rely on microscopy. We rely, first of all, on the patient's symptoms. We really kind of want to hear that she's got itching, irritation, and then we rely on microscopy. Occasionally, I will send a culture, but usually it's more for ruling out yeast vaginitis. I have women who will come to me and say, oh, I've been told I've had yeast infections for years and I can't get rid of them. And I'm like, yeah, right. I look under the microscope, everything looks great, they don't believe me, so I'll say, well, I'll tell you what, let's send a culture, because if it comes back with no yeast, then I really think we don't have yeast infections here. If it comes back just in the general screening with yeast, that doesn't tell you a lot, because about 20% of women could be colonized. So I don't use cultures that often, but in some cases I do. If you run across a patient that does not respond to the single-dose flagell, do you look for other agents? Mobiluncus adipobium, BVAB, which is BV-associated bacteria, that might be causing symptoms. Well, hopefully, I have already done some type of testing for bacterial vaginosis, and I tend not to do molecular testing for that. I tend to rely on either the Amsel criteria, pH with clue cells, discharge, or the Nugent score, where there's a grading of the vaginal flora. So I'm not a big fan of searching for individual organisms that might be associated with BV, such as adipobium or mobiluncus. So if she hasn't responded to single-dose flagell, I would have hoped I would have already known she had BV and gone ahead and treated her with a week, which brings up sort of another question that I sometimes get. What do you do in the woman who has a mixed infection, which is pretty common with Trich and BV? And in that case, I sort of err on the side of going longer, and I'll treat her with metronidazole 500 BID for a week, which obviously will get both the Trich and hopefully the BV. And it looks like we are about out of time for questions. So I want to thank you all for joining our webinar, and I hope you've enjoyed it. And I wish you good luck in Trichomonas hunting. Thank you.